doctor level, and we are a team that works in the community, and our primary role is to prevent people from going into hospital. So say a GP turns up at somebody's house, they're unwell, but he feels that sending them to hospital, which would have been the old traditional response to that illness, would be of detriment to the patient, or the patient just doesn't want to go, then we'll get involved instead. But not only do we manage their medical problem, we also treat them socially, and also look at their home environment and what things are making them unwell. So it's not just a case of throwing some pills at somebody or giving them some medical treatment. It's about looking at them as a whole person. We also look after a lot of care homes and nursing homes, and I've done for many years, even before COVID came along. So within Rochdale, there is 46 care homes and nursing homes, which is quite a high proportion for any borough. And we help prevent those people from those care homes going into hospital when it's not needed. So they're already frail, unwell. Sending them to an A&E department to sit there for 3 hours waiting to be seen is not going to be very good for them at all, taking them out of an environment they already know. They may have dementia, so that will make that a lot worse. So we try and treat them in the care home, or we try and divert them around an accident emergency department, so we have the ability to refer directly into specialities, which is quite unusual for nurses, OTs, physios to be able to have that access, but we're all quite advanced trained. So that's my job at the moment. And I'll tell you a little bit about how I got here, because as you can see, I'm not a young spring chicken. I didn't start nursing last week. I've been doing it for a little while. So when I started my nurse training, it was way back in 1990, which I should think is way before most of you were born. And it was at Bolton Hospital in their little school of nursing there. And there was just a cohort of 20 nurses every 3 months that were admitted. And our nurse training was actually based on the wards and units within that health authority. It wasn't university based. We were paid a salary to train. Wasn't a lot, but we were paid a salary. And a lot of us actually lived in a nurse's home within the hospital. So that was how it was done a lot of the time in the past. But during my nurse training, they actually started to move it more towards university with something called Project 2000. And to start my training, I only had to have 5 O-levels, so 5 GCSEs. Didn't need A-levels, wasn't university based, like I was saying. But I did actually have A-levels. I had 2 A-levels before I started. And when I left school, I had no qualifications whatsoever and did GCSEs and O-levels at Further Education College. So, and when I completed my nurse training, believe it or not, even in these days of news stories about shortages of nurses, there was a complete ban across the NHS of employing any new nurses. So I had to hunt around for a job, which was quite difficult. So I had to work on the bank. So working as a bank nurse within the NHS, working in a variety of different units. So say somebody rang in sick for a day, or they'd done their planned work and they found that next Tuesday there was going to be nobody on duty. They would put a request through to a bank, and you would sign up to the bank and say, yeah, I'm available next Tuesday. Oh, can you go and work in urology, for instance? Oh, yeah, fine. Or a phone call, are you available today? We've got somebody ringing sick on this ward. Can you go and work there? Yeah, fine. So that was me for the first 3 months of my nursing career. So it did give me a lot of variety, a lot of work. I was working 60 hours a week, which you wouldn't be allowed to now, on the same ward. But they couldn't employ anybody because they weren't allowed to, even though I was doing the job. So very strange times. So eventually I got a job working in care of the elderly. So it was people who had been acutely unwell in hospital with, say, heart problems or a stroke or a chest infection or something like that, really poorly. But they weren't quite ready to either go back to home or back to a nursing home or care home. And they still needed a little bit of looking after and monitoring, or they were waiting for placement in a care home or nursing home or something like that. So they would come to us and we would keep an eye on them and look after them, and eventually get them right and get them to where they needed to be a bit more permanently. So I did that for a few years and then went working on acute medicine, so where people come in with acute heart problems, chest infections, strokes. The ward where I used to work particularly used to deal with gastroenterology, so that's anything to do with your gut. So we used to deal a lot with people with liver disease, so that included a lot of people with alcohol dependence. So we used to deal a lot with detoxing alcoholics and people with liver problems and things like that. And then after 10 years of doing that in various units and also being a manager doing that as well, I decided to move on in my career and went to work for NHS Direct. I don't know if anybody of you ever heard of that, but it was the precursor to 111, which now is a telephone triage service. But when I joined it, it was run mainly by nurses. So when you rang up with a problem, say you've woken up during the night feeling a bit unwell, being a bit off colour for whatever reason, and you would ring NHS Direct and you would speak to a nurse directly. You wouldn't speak to a call handler or somebody just going through an algorithm on a screen telling you, asking you about your condition. You would speak to a nurse. We did use an algorithm on a screen, but we could use our clinical knowledge as well to override it and augment it. And that at the time was run by the local ambulance service, which was Greater Manchester Ambulance Service. So before it amalgamated to Northwest Ambulance Service. And we used to have opportunities to work on projects that GMAS were doing. So during that time, I went working in the control room, which then was in Bellevue in central Manchester, doing secondary triage of 999 calls. So somebody, don't know if any of you have ever rung 999, but you would ring 999, the BT operator would put you through to ambulance service if that's what you asked for, and then you would be triaged by the ambulance service. And really all they're interested in is the patient alive or not alive? Is the patient breathing or not breathing? Are we dealing with a real emergency? We've got to send somebody to you rapidly, or is it less of an emergency, or even less of an emergency, or not an emergency at all? And their problem at the time was they had a lot of not emergency calls that they couldn't deal with. They weren't allowed to say, get lost, you're not an emergency. They had to go and see them. So they employed people like me to then secondary triage them. So I would tell people, no, an ambulance service is not going to deal with your toothache, for instance. You need to ring this number for an emergency dentist. Things like that. Or, ring your doctor in the morning. This is not an acute emergency. It's not something the ambulance service is going to deal with. So that's what our job was, doing a project to establish if that could be done safely and well. And it established that it could be. And most ambulance services now have something similar. So for instance, here, if you ring 999, it's not an emergency, then more often than not, you're going to get somebody ringing you back who's a clinician, a nurse or a paramedic saying, what's all this about? What have you rung about? What's the problem? And then they would direct you elsewhere. So that was the start of that project. And I then went from NHS Direct to working in a walk-in centre and then running walk-in centres in Bury. So walk-in centres are for people who feeling unwell, they just come in on the day and sit down and wait, and then you get seen in turn. So it's not like an accident emergency department where you go in and you see a triage nurse who decides if you're poorly or not poorly, if you need to be seen immediately or a little bit later or anything like that. It's just you come in, sit down, wait your turn. We would look for things on our computer queue that would be a bit more of an emergency. So for instance, if somebody came in clutching their chest and going blue in the face, then the receptionist would let us know, and we would see them very, very quickly. But most of the people who we saw were not poorly ill. So for instance, they've got a chest infection, or they've got a cough or something like that they want somebody to tell them whether they need treatment for or not. And it was an entirely nurse-led service, so no doctors there. So we would see, assess and treat purely on our own. And to do that, you have to be a nurse prescriber. So while I was there, I did my nurse prescribing training, so I can write prescriptions for any medication I feel competent to write them for. Exactly the same as a doctor. Exactly the same rules around a doctor writing them, just mine are a better colour. There's a boring green, mine are a nice lilac. So that's been invaluable during my career. So a lot of nurses who are sort of at my stage are nurse prescribers as well. So you have to do a course at university to do that. But it's just an additional course for 3 months. And hey presto, they let you loose. So in the walk-in centres, I ran 2 walk-in centres in Bury. So I was the clinical lead nurse there, doing all the stuff that needed doing there. And then I decided to have a change, and also because the government of the time, about 5 years ago, decided that all walk-in centres needed to be got rid of. Unfortunately, the NHS is very much at the whim of politicians to some extent, and walk-in centres were instigated by a Labour government back in the 90s, and then a Conservative government came along and they were opposed to them purely, I think, because they were a product of Labour. No other reason, because they worked very, very well. So we had to move on. So I then came to work here with the rapid response team. And like I say, my main job is looking after care homes and preventing people from going into hospital unnecessarily. At one time, we used to have a rapid response vehicle, an ambulance, that we would answer 999 calls with and back up the ambulance service with. But at the beginning of the pandemic, that was pulled, although there is talk of it coming back soon, once things have settled down a little bit more. So that was an ambulance that would be staffed by a nurse, an advanced practitioner, with an ambulance technician, and they would go around on blue lights, answering 999 calls, but they were the low-grade 999 calls that would probably have a good chance of you being able to divert that person from hospital, either because they've had a history of ringing 999 with not a lot happening, or because of what they'd presented with is something that was within the scope of what we could treat at home, or direct elsewhere. So once we'd assess them and make sure that they were safe. So that was quite a successful thing. It was called a heat car. So nursing generally is a profession that acknowledges learning and knowledge acquired. It's not all about what pieces of paper you have that say you can do this, that and the other. There are some things, for instance, I can't prescribe unless I have done my university course and passed it to be a nurse prescriber. But a lot of the time it's about your experience and what you've learnt over your career. You may compound that with some university learning and additional learning as well. But a lot of the time it is about what you've learned and how you present it in your career and your experience and knowledge. So whilst nursing at the moment is a degree entry, you need to do a nursing degree at the moment. Once you are qualified, you can actually go quite far without having to do an awful lot of further university training. You don't have to have a master's in this and that. You can progress quite well. And I'll let you into a little secret. I don't even have a degree. So I've got all this way to quite a senior nurse, and I've never converted to have a degree. But that was just the way that my career pathway went. It was never planned that way. It's just the way it happened. So I don't know if any of you are interested in nursing as a career or healthcare as a career. But just some little things specifically about care home and community nursing. So not necessarily what I do, although I skirt around the edges of it a little bit. So community nursing is generally, it covers a whole number of different nurses in different specialisms within community who look after people in their own home largely, or in a care environment that is their permanent home. So that can include district nurses. It can include an advanced practitioner, so that's a nurse or an OT or a paramedic or a physio that have then gone on to do a master's degree in advanced practice generally, which is a 2-year course that you do when you've got to a quite fairly senior level, and they are then an advanced practitioner. So they're almost like doctors really. And they work in a variety of different localities, but some of them work in community, some of them work on our team. Also, there are specialist community teams like respiratory service. So they have nurses that look after people with respiratory problems, particularly one called chronic obstructive pulmonary disease, COPD, which is what you get if you smoke a lot or you worked in certain industries. So it's a lung disease, debilitating lung disease. Quite often they can end up on oxygen, they can end up isolated at home, and become acutely unwell quite quickly and easily. But there are some very simple things that can be done to keep that person reasonably well. So the respiratory team monitor them, keep an eye on them, act as a resource to help them. So they telephone them if they're feeling unwell and talk to them about what medications they're taking, how they're taking them. They even go and see them and go through all their medications with them and things like that. And education as well about their condition and how to manage it. We also have stroke team, so people who have had a cerebrovascular accident, a stroke, so a blood clot has formed inside the circulatory system around the brain and blocked off oxygen supply to part of it. They can be quite disabled by that, but some people recover quite well. So they may go home, but they still need continuing monitoring to manage their condition, to learn how to live with their condition. But also the recovery can be quite gradual and slow. So you can start off being quite unwell, but over a course of months or even years, you can recover quite fully. So the stroke team help people in that recovery. They also have physiotherapists who help with the more physical aspects of how that affects people. So they could have numbness. They also have ties into the speech and language team who deal with people whose speech or swallowing has been affected by a stroke and helps them to manage it. And we also have a neuro team, so people who have had more profound neurological problems. So, for instance, motor neuron disease, or have had brain injuries or bleeding in the brain, things like that, things that have really affected the brain a little more profoundly, or maybe debilitating and worsening conditions that affect the brain and affect the nerves through your body. They monitor and help people with those conditions in their own home. So those people don't have to spend as long in hospital. They can be looked after in their own home. They can still receive specialist import at home. But most of the people in these teams are nurses. They may have specialist physiotherapists and occupational therapists and people, but most of them, the backbone of these teams are nurses. And why nurses? Because we have a much broader range of experience through our training. We have much more of a fully encompassing view of the patient and all of the conditions that can affect them. And usually when we're working in teams like this, we've usually been around a little while, so we've got a lot of experience. Most of these teams, their impact is to try and help prevent people going into hospital. And why is that important? Well, it's important for the patient because they don't particularly like being in hospital. Unless you really need to be there and you're really poorly, it can be a daunting place and not a great place to be. And most people who are in hospital want to be out again because they want to be well. And also some patients going into hospital presents them with risks that you want to overcome. You'd rather not expose them to that. So for instance, somebody with COPD, with lung disease, if they're in hospital, they're around more germs, more bacteria, more other people who have got lung disease and coughs and chest infections. Whilst you might have one particular type of chest infection, the guy in the bed next to you might have a different one. It has been brought to light by COVID, particularly. We knew these things before, but it really put a focus on things like that, on hospital-acquired infection, which may be nobody's fault in the hospital. It's just purely you're in the same environment, breathing the same air, and bugs are everywhere. Just as a little aside, I don't know, you don't have to answer this, but how many bacteria, fungi and viruses do you think are living on your body and in your body at any one time? Have a little think, pick a number. $10 trillion body cells in various shapes and forms. In your body, you're outnumbered at a minimum 10 to 1 by bugs. So that's just in you, in a healthy individual. You've got about 100 trillion viruses, fungi and bacteria living in you. And it only takes one to do you some harm. So just to put everything in perspective a little bit. So another reason for keeping people out of hospital is because there isn't the space for them all. So within Oldham, where a lot of you guys are, you've got a mid-sized district general hospital, not a particularly big hospital, it's medium-sized. In North Manchester, which is not too far away, you've got a slightly larger district general hospital, but still reasonably mid-sized. Salford, you've got a teaching hospital, which is a bit bigger, but it's mainly dealing with specialist stuff. So if you saw a consultant in Oldham and you had something that needed a specialist to deal with it that was particularly different, then you might be referred to a consultant at Salford, for instance. Bolton, not that far away, where I'm actually from, where I live. You have a larger district general hospital, that's a bit bigger than Oldham. Fairfield, which is in Bury, another mid-sized district general hospital. And Rochdale has what in a lot of places would be called a cottage hospital. It's quite small, but they don't call it that here because people get a bit uptight. But it's a cutesy name of a cottage hospital. It's quite small. It only has a couple of wards in it, but it still does a lot of treatments here. And why that's important to list those hospitals is they've all lost beds. Large numbers of hospital beds have been reduced and got rid of over the years as the NHS has become more efficient at treating people because people haven't had to stay in hospital as long. So for instance, in 1987 to 88, nationally across the country, we had 299,000 NHS beds. Sounds a lot. So nearly 300,000 hospital beds of various types. So that's mental health beds, acute beds for people who are really poorly, slightly longer stay beds for people who are staying in hospital a little bit longer. Now, in 2018 to 2019, that has reduced to 141,000 hospital beds. So it's reduced by more than half. So that's why it's important to keep people who don't need to be in hospital out of hospital, because there isn't the room for them at all. And we've increasingly seen that a real sharp focus again during COVID has been placed on that, because we didn't want people in hospital unnecessarily. One, with other conditions, because they might catch COVID. And two, we didn't particularly want them with COVID there, because they might give it to people with other conditions. So we were trying to keep as many people out as possible. And during the pandemic, our team was supporting people in their own homes who had COVID-19. We were monitoring them, keeping an eye on them. If they needed oxygen therapy, then we would have to move them to hospital. But we were keeping them there as much as possible. Even if they were a little bit unwell, we were still keeping them at home as much as possible. So how am I doing so far? Are you all asleep yet? Nope. Okay. No, nobody asleep? Drew's awake. Joe is awake, so that's good. Okay. So, care homes. Care homes have increased in size. I mean, just within Rochdale, we've got 46 care homes and nursing homes. That's elderly registered care homes and nursing homes. We have other ones that deal purely with people with learning difficulties and mental health problems, but purely the ones that deal predominantly with elderly people who may have other conditions as well. It's 46. That's quite a high number. For instance, in central Manchester, they only have 12. So it's quite a difference. So why in Rochdale do we have so many? Well, there's three reasons. One, cheap buildings. So the property up here is cheaper than in central Manchester. Two, cheaper workforce. There's more people living up and around the Rochdale area who will work for low wage or minimum wage on a carer's wage, whereas in Manchester there is a smaller workforce pool. And three, there's a lot of elderly people up in these areas. A lot of older people have moved out of Manchester city centre because their properties have become very expensive. So economically, they're pushed out into the surrounding towns. So we end up with a lot of people in that situation here because of purely demographics. But the main reason is because of cheap buildings and labour. That's why a lot of them are here, because elderly people move from Manchester and from more expensive areas to be cared for in cheaper areas. So as a national statistic, the number of care home beds to hospital beds, any idea what sort of ratio that might make? Do you think it's 1-to-1? No, maybe 2 care home beds to 1 hospital bed. That's 3.2 care home beds to 1 hospital bed. So across the country, there are over 3 times more residents, people being cared for in care homes and nursing homes than there are in hospitals. So it's a huge population. And in care homes, for instance, there's no healthcare professional in the building. Carers, they have some training, but they're not professionally trained, and they manage very, very well. I was surprised when I came to this job what sort of things they do deal with and manage with by learning from each other, by passing on experience. They do very, very well. And you usually have carers and senior carers, so carers with more experience who are running the shift or in charge of the care home when the manager's not there. The problem arises when they hit something purely medical or something medico-legal, like for instance, somebody falling, their companies, because they're all privately run, would prefer a healthcare professional to check that person over to make sure they're not injured. So they tend to ring us. But also when they hit medical problems. Working in a care home can be very rewarding, a lot of variety. Usually you build up a really strong relationship with your residents. They almost become part of your family. Even I found that, even across 46 care homes, a lot of people recognise me now. I don't know if it's because I'm distinctive or particularly ugly, I'm not too sure, but a lot of people do recognise me now and say hello when they see me. So, I don't know if you want to hear a little bit about some things that I've come across during my nursing career, just to whet your appetite of the kind of things that you can be involved with. So I'll tell you a few stories. Okay, nobody fall asleep, don't nod off. Okay, so the first one is a guy that I saw when I worked in acute medicine a few years ago now, who he was in Bolton on the acute medical ward that had one of its specialisms was stroke patients. So we had a lot of elderly patients who'd had stroke. And he was an ex-RAF bomber pilot, and then he'd trained as an engineer. He was a very proud man, always looked after himself, always looked after his family, but he had a sudden stroke, and he was admitted to hospital, not to our ward initially, and then he went to a rehabilitation unit to try and learn to deal with the after effects of his stroke. So one side of his body wouldn't move, his arm and his leg couldn't move them, and he'd lost a lot of his ability to speak because it had affected his speech centre in the brain. Incidentally, women don't lose their ability to speak very often during a stroke. Don't know what conclusion you can draw from that. It's mainly men. So he came to our ward because he'd become unwell again on the rehabilitation unit. His stroke had worsened slightly, and he'd also developed a chest infection, pneumonia, because he was immobile, he was bedbound, he was getting out of bed on occasion, but his lungs weren't able to fight off those 100 trillion bacteria that I was talking about before. One of them had got a hold in there and was trying to make him poorly. So he came to our ward so that we could treat him more effectively, because we were an acute medical ward. So we had more doctors, more nurses per patient. We were able to give intravenous drugs, so drugs straight into a vein, so antibiotics straight into a vein. He'd also been eating at this point, but now he was no longer able to eat because he wasn't conscious enough to swallow. So we had to feed him through a nasogastric tube, which is a tube that goes up your nose and down and into your stomach, which feeds you directly into a stomach through a liquid. So we were doing that for him. And I can remember he was also had a really dry mouth because he was a bit dehydrated when he came to us, because he'd been unwell for a little while. So I did a lot of mouth care with him. And I was the nurse that predominantly looked after this gentleman when he came to our ward. And at first it was thought that we were treating him, but he might not make it. So we were not going to resuscitate him if his heart was going to stop. His family were informed of this. They were informed of that decision making. And because I was the nurse that mainly looked after him, I grew to know the family quite well. And I grew to know this patient quite well. And when he recovered, so I've given the game away a little bit there, he did recover quite well. He said that he thought that I was an angel. Can you imagine the most unlikely looking angel you have ever seen in your life? But because he couldn't see me or hear me properly, he just knew that there was somebody there, and it was the same person regularly. So when he came round a little bit, he referred to his family. He couldn't speak very well, but he kept on saying the angel, and he was referring to me. So when he got better, he said that was me. So we had a bit of a joke about that, because I really don't look or even didn't speak like an angel particularly, but it was just because I was there regularly. So I always remember him because of that. And also talking to him about his wartime experiences whilst we were looking after him, whilst we were delivering care, and talking to his family. And his family were very grateful that we'd really sort of brought him back from the brink. And eventually he was on our ward for about 5 weeks. So it's quite a long time to be on an acute medical ward. And eventually we sent him back to the rehabilitation unit, which is only in the same hospital, just a different ward, where he had intensive physiotherapy and stuff, and eventually went home. But unfortunately, 2 years later, he was admitted back onto our ward again because he'd become unwell again, and he did die on our ward. And again, I was the nurse that was looking after him. Again, I was the one dealing with his family. His family were very grateful for that continuity. They knew who was dealing with him, and I was there with his family when he passed away. So you build up quite a strong relationship with some of your patients, even ones that you've only seen briefly. So again, another patient, this was in a walk-in centre, only 4 years or so ago, less than that. It was a 3-year-old little boy who was brought into us. I'm not a children's nurse, I'm just purely an adult nurse. But because during our nurse training we had a children's placement, we are deemed knowledgeable enough to look after children as well, if need be. So in the walk-in centre, about 40% of the patients that we saw were actually under 16. So we would see them even though I'm not a children's nurse. And his mother brought him in a blind panic. His mother was actually a nurse, but she was panicking. All that nursing gone out the window because it's her little boy who's really poorly. And he was short of breath. He'd developed a rash, and he was very distressed. So we very quickly decided he was suffering from anaphylaxis, and he had asthma, this child, and he'd had a little bit of a temperature, a bit of a cough, and his mum had given him some over-the-counter cough medicine, and the child was allergic to something that was in the cough medicine, and that made him really ill. So we had to inject him with adrenaline very quickly, ring for an ambulance. But because we're in a place of safety, which is a walk-in centre, because there's a healthcare professional there and we have emergency equipment, we tend to get not to the bottom of the queue, but if there's somebody in the street who needs an emergency ambulance, they're going to get it before us. So it took a little while for the ambulance to arrive, and I ended up injecting him 3 times with adrenaline to keep his symptoms under control. And he was taken off to hospital very, very quickly with oxygen and other medication to help him breathe, and made a full recovery. Was in hospital for a couple of days, but made a full recovery. And lo and behold, when I came to this job, his mum worked in the office next door. So I remember that child, but she made me remember it even more. She said, I remember you. And I remembered her. So that's one that sticks in the mind. So it goes from long-term care to something very short-term. I was only with them for a matter of an hour, and it's still there. And one more, what I've written down. Nope, that was it. But what I wanted to say as well was, oh yes, there was another patient, another one I can tell you about. Was in the team that I'm on now. So this is one that I saw in community. She was a lady who kept on making repeat 999 calls. And you might think, oh, what a nuisance. These 999 calls, she was never taken to hospital. There was nothing really seriously wrong with her. We think of in our healthcare professional head, and even in a lot of lay people who would think, well, there's nothing wrong. Why should she keep on ringing 999? But it was because she was scared. She was frightened. She was in her 70s, but reasonably well in her 70s. She used to look after her garden and her house very well. She lived in Middleton. And she kept on ringing up because she was having heartburn, really severe heartburn. So burning sensation in the chest. but it's being caused by not your heart, it's being caused by acid coming up into your esophagus from your stomach. So imagine after you've had a really heavy meal or something like that, you're feeling a bit of an indigestion. So like that, but she hadn't eaten anything, and it just kept on occurring, and it was frightening her. Eventually, we persuaded her that she needed to see the GP, so we arranged for her to have a consultation with her general practitioner, because we were suspicious about this heartburn. It had come on quite suddenly, quite quickly. She wasn't eating, she'd lost quite a lot of weight. So we have something called a 2-week rule, which if somebody could be suffering from symptoms that may be caused by cancer, a large number of them are not caused by cancer, but it's a symptom that could be, we need to establish that either it is or it isn't very quickly to get treatment started straight away. So even if the vast majority of patients do not have cancer who have these symptoms, they all have to be referred on a 2-week rule to rule that out. Because if you miss it, if you leave it too long, it's devastating for that patient. They could end up dying. So we refer them on what's called a 2-week rule, where they see a specialist. So she was referred, but she was still making 999 calls, and very anxious, and she was given some treatment for her heartburn as well, but she didn't take it properly and all sorts of things like that. So that's where we really became involved, and we used to go and see her every day and reassure her, make sure she was taking her medication properly, make sure she was taking some food, and she was put on some supplement drinks to try and stop her losing weight quite so rapidly, and make sure she was drinking plenty of fluids. But it very quickly became apparent that she was just very lonely and very scared. She had no immediate family. She had a neighbour who used to call round quite regularly. So what I used to do, even after it had been established that she didn't have cancer, I used to try and go round in an afternoon at about 3 o'clock, because she lived next to a school. And we used to sit in her front garden, her beautifully kept front garden, and just say hello to the parents and the children going past. And just doing that made her feel so much more connected to what was happening around her. And some of the parents after a while would stop and talk to her, and she'd never had that before. So it just made her feel that she was part of what was happening around her and more connected. And it removed an awful lot of her anxiety and her fear. And she stopped ringing 999, because she was still ringing it even when we were involved. But it stopped her from doing that. And we also managed to get a volunteer service that would go and see her every week or twice a week and just say hello to her. She didn't really need carers. She didn't need looking after, but we got somebody to come and help her, a carer to come once a week to help her with her shopping as well. And that just improved her life immeasurably, because suddenly she was connected, she wasn't lonely, she wasn't fearful anymore. And that really made a big difference to her. And I was just going to finish off with just saying about, I don't know if any of that has been useful to any of you, but saying about nurses and healthcare professionals in general. A lot of what we do is not about what we know and our medical technology or knowledge. A lot of it is down to communication, talking, communicating with people, not even getting inside their head. You don't need to know psychology or anything like that. You just need to be a human being and know a little bit about life. So just another statistic for you. I'm not a big fan of statistics, but some of them do stick in your mind. So across the NHS, we deal with complaints every day. Every service deals with complaints. I've had a few. You just deal with them as they come. But 80%, and I have to say none of mine, but 80% of all complaints within the NHS, when you get right down to what's caused that complaint and caused people to be upset and annoyed and moved to complain, is poor communication. Is because somebody somewhere didn't communicate something effectively or properly, or left something out, or didn't say something. And then it sets off a whole chain of resentment and anger. So most of what we do as healthcare professionals, and nurses in particular, is communicate. Communicate, both talking, both in our attitude and in how we deal with people, and we listen and communicate. So that's what we do. And you don't need to be a super being to be a nurse. You don't need to be any of those things. You just need to be able to communicate. That's the main key. So if any of you are good at talking, and I'm sure your friends will point that out if you are, or listening, that's the job for you. But it's a skill you can learn as well. But if you've got it already, it's even better. But that's what we do. So that's it. I've run dry. I've run out of communication. So if anybody wants to ask me anything, go ahead.
We'll see if anyone's got any questions. Well, thank you, Colin. That was very interesting. We'll see if anyone puts any questions in the chat. But that was very interesting.
Hope it wasn't too boring.
No, it was actually very interesting.
Yeah.
Gives you a different side of nursing.
Okay. Because like I said to Joe before about me talking, people have rugby tackled me to the ground and then puts gaffer tape over my mouth in the past. So, yeah.
Well, if no one has any questions... Oh, no questions from Barry. Thank you, Michelle. Thank you all for coming as well. If no one has any questions, we can let Colin get back to work.
I can, briefly, if you've got a minute, I can just show you where I work.
Oh, that'd be brilliant.
That'd be helpful. I have primed them to be cheerful. So I was in a little tiny office there, but we're in just at the back of the hospital. This actually used to be the A&E department, but they've repurposed it as the community hub. So a lot of teams are in here. So I can just turn you around and you can see there's an office out there. Anybody feeling cheerful? You want to wave to these students from Bury and Oldham? Yeah, a few people, quite a few people visits, so they're all waving to you. Yeah. Or I better disappear. My manager's come down. She's in the corner over there. So that's where we work. It's a fairly nondescript office, but most of the time we're actually out and about seeing patients out in community. So we're zipping around in our cars from place to place. So, yeah, that's it.
That's it. Well, thank you very much, Colin. Okay. We appreciate your time.
No problem.
And thank you all for attending. And we'll speak to you next week for the rest of the colleges. Bye.
That was of use. Bye-bye.
Bye-bye. Thank you, Colin.
Thanks.